who was involved with the Christian Medical Fellowship and is now involved with International Christian Medical and Dental Association. So over to you, and I'm moderating that one.
Thank you very much. It's a privilege to be here and to hear these talks and react with you in perhaps a different kind of way. So I've been asked to give a medical perspective to this. I was with CMF. I'm now CEO of the International Christian Medical and Dental Association, which brings together 84 national movements of Christian doctors and dentists throughout the world. So what I'll bring is in part a global perspective as well as, I hope, a UK perspective. Now, these are the realities. Globally, cases are going up still, 400,000 cases a day, which is the highest it's been measured. And we're still seeing, and have seen for the last 6 months or so, an average of 5,000 deaths a day worldwide. So no sign of any end to this at present. But the patterns in various countries are different. I come from New Zealand, which has been very successful, just 25 deaths, 5 per million population. You've got other countries like India, which have journeyed up to a long peak and are now down. They're saying by the spring they'll be back down. There are others that have had initial spurts and then have had great difficulty maintaining control after that. The United States, a classical example, and then many of the countries of Europe have been like the UK, where there was initial spurt of deaths. These graphs all apply to deaths, not cases, on this page, and then we're now starting to see them rise up again. So ongoing, these are the stats that are put out each day for the world. So over 1,100,000 deaths thus far, and half of all these deaths have occurred in just 4 countries, USA, Brazil, India and Mexico. But probably the best measure, you can see UK is number 5 there, but the best measure of the severity in any one country is the deaths per million population, where actually it's Peru that leads, and 5 of the top 10 countries in this measure are actually in Latin America at the moment. Seroprevalence, if you've got antibodies and therefore have definitely had the disease, it's still in most Western countries below 10%. You can see the figures there for the United Kingdom at 8.6%. This is on the Lancet's seroprevalence tracker, which you can review. We know the vast majority of cases are mild, 80%, 20% get into hospital, 5% critical, half of those die. And most of those who die are in the 60 plus age group, more than 90%. In fact, if you're in your 60s, 3% chance of dying. If you're in your 70s, 8%. If you're in your 80s, 15%, and so on. So they're a high-risk group based on age, but also those with existing conditions, cardiovascular disease, diabetes, chronic respiratory disease, and so on. If we take 100 people who die of the disease, then only 1% of them have no associated conditions. So this is really a disease where those most vulnerable are going to die, and there are very well-defined conditions of who is vulnerable. Sex is a risk factor, twice as dangerous in men as women. We know ethnicity is another risk factor. Black and Asians are much higher risk. How contagious and deadly is it? Well, this is the percentage of those who die, and along the x-axis, the infectiousness, how likely you are to pass it on. And you can see that COVID is somewhere within this rectangle here, along with Spanish flu, nowhere near as dangerous as bird flu or Ebola, which killed 50 to 60% of people, and nowhere near as infectious as measles and chickenpox. And I think here we see the extraordinary mercy of God. Imagine if we had a disease which was as infectious as chickenpox and as toxic as Ebola. But it is the major killer amongst all the infectious diseases in the world today. So you can see right at the top of the list above TB, hepatitis B, pneumonia, etc., worldwide. That's the reality of it. Vaccines, 170 teams of researchers, but only 11 of these are at phase 3 level. None have yet been approved. So we're still some way away from having a vaccine. We know that some treatments work, in particular steroids especially dexamethasone, will reduce your death chance by a third if you're on a ventilator. Remdesivir is one of the antivirals which has been shown to work. And there are methods that doctors can use in intensive care departments, prone positioning, so nursing people face down, and also the use of ventilators and other respiratory support devices. So no vaccine yet, some treatments, but no cure. So let's sum all that up. Overall, how serious is it? Well, we have been extraordinarily effective in slowing the spread of this for what might have happened, but we're already over 1 million deaths in 8 months with no sign of abating. At current rates, there will be 2 million deaths by the spring of next year, and yet the national seroprevalence in heavily affected countries like the UK is still 8 to 10% or less. How serious is it? Well, there's great debate about this. I think we can come back to this, but the infection fatality proportion, in other words, the proportion of people who get infected who die, is probably around 1%. If you put this up against the worldwide population, with the risk of 0.01 of dying, 80% to herd immunity, you could be looking at this level of deaths potentially. Of course, we're way, way below that at the moment, and there are lots of other variables that play into it. No vaccine or curative treatment, and the collateral economic and health damage is overwhelming. So it is a serious pandemic. These are the worst plagues in human history. Those that are marked in yellow are the top 7. We're nowhere near that level yet, but we are certainly getting into the top 10, and will be comfortably in the top 10 by April of next year, the way things are going at the moment. But there have been extraordinary collateral effects that we all know about too, and especially on health. This came from the Lancet, leading medical journal, back in July. This pandemic is dismantling the foundations for protecting and advancing health. Global health has entered a period of rapid reversal. De-development is the new norm. Now, we could spend a lot of time on this, and we have to go through it fairly quickly because time is limited, but lockdown leading to hunger and famine, people being pushed into extreme poverty, worsening mental health, the problems of family breakdown, domestic abuse, and also that critical medicine for other conditions is inaccessible because of lockdown or COVID patients being prioritised in a limited health system. So we're seeing in reality a whole lot of surges of different diseases. So this purple line is the COVID mortality and morbidity, death and sickness, followed by the green one, which is the restriction on urgent non-COVID conditions, so heart disease, cancer, and so on. And then the impact of interrupted care on chronic conditions, people with high blood pressure, diabetes, and all of that. And the red line is the psychological trauma or mental health diseases. So there's no question that the management of COVID has collateral effects on other diseases. It's estimated we'll put 71 million into extreme poverty, 260 million to face starvation by the end of this year. And it's obviously not in the UK, but these are worldwide global figures, and we're members of the global church. The estimate is that more children will die from missed vaccinations than people who die from COVID-19. That came from the from the WHO itself. And years of progress against vaccine preventable diseases, because vaccines are not happening at the same rate in all the diseases that are listed here. Impacts on HIV, TB and malaria, 1.5 million extra deaths there. And then non-communicable diseases, these are things like cardiovascular disease and cancer, which are killing accounting for 70% of the 57 million deaths there are globally each year. And you can see the delays in treatment. 53% have partial or complete disruption for high blood pressure treatment, similar figures for diabetes, cancer, cardiovascular diseases. And then mental health, this was a report that came from the Centre for Disease Control from the US. So these are US figures, but the UK figures will be similar. Anxiety in young people tripled, depressive disorder quadrupled, 25% of 18 to 24-year-olds have seriously considered suicide. And so these are all things that we're painfully aware of in our own congregations, collateral effects on health. And so overall, how would I sum this up? Well, I think we're in a situation really where we are like Odysseus trying to sail his ship between Scylla and Charybdis, the six-headed monster of Scylla, who if he got too close would pick his men off the deck, or the whirlpool of Charybdis, that if he drifted too far away from Scylla would take him down into the watery depths. And we have the Scylla, if you like, of coronavirus itself and the effects it causes, and the Charybdis of the collateral effects on other kinds of other areas of health, and also of the economy and all the effects there. And so we have this abundance of exponential curves. I think that one of the main curves we've noticed in the medical profession is the exponential increase in the number of people with a PhD in epidemiology, and especially in the churches. But this is an incredibly complex, multifactorial problem. We do know that social distancing, hand hygiene and masks are very effective in slowing down the spread. We know because of countries like New Zealand, Taiwan, Vietnam, which have done it very effectively, that test, trace and isolate is incredibly effective, sometimes in bringing complete elimination of the disease. We know lockdown flattens the curve and enables the health system to readjust or prepare for a wave. We know that going for so-called herd immunity risks huge mortality because of the figures I've shown, and that we're nowhere near a cure or vaccine yet. And so I'm just going to touch on some of the controversies, because this is such a complex problem: protecting the vulnerable versus protecting the economy, lockdown versus release, elimination versus moderate control. What is the actual infection fatality proportion? There's some debate about that. And then focus protection and herd immunity versus controlling community spread. So just looking at each of those briefly. In turn, these are some of the economic effects: the massive drop, increase or fall in the stock market, the massive increase in national debt right across the Western world, especially in those countries which have attempted to provide support for people who are out of work. Countries, the red ones, on the brink of recession throughout the world. And of course, the world economy is struggling with rising unemployment. So, and all the knock-on effects on health of those indices. This was a letter from the UK's leading chief medical, from the public health doctors in the UK, published in the BMJ to the UK's chief medical officer, including Chris Whitty and so on. And they were advocating a middle path. Rather than absolute measures, lockdown or release, we should take a more relativistic approach of more relaxation or stringency, depending on control of the virus. I can give you all these references, but that's a great letter to read. The question about whether elimination is possible has divided medical opinion in mainstream peer-reviewed medical journals. So you've got a head-to-head here in the British Medical Journal talking about this one. And of course, elimination has been possible in places like Vietnam, New Zealand, and so on. But whether it's possible in countries like the UK, where the disease is already well established, or whether we've got to live with some level, is a much more open question. What is the infection fatality proportion? In other words, what percentage of people who get it die? Well, it varies in different populations. I think the best article to read on this, if you really want to know the facts and the confounding variables, is Rod Jackson in the New Zealand Herald, where he's saying his bottom line is that it's somewhere between 0.5% and 1.5%. So this is 10 times more deadly than the flu. And then I think a lot of you will be aware of the controversy around the so-called Great Barrington Declaration, which came out a couple of weeks ago, arguing effectively that we should allow schools to open, universities to open, people to go back to work, life to happen more or less as it did, but to protect the vulnerable, and whether that was possible, that herd immunity was closer than we imagined And then the response to that, which is the John Snow memorandum just published in the Lancet 2 days ago, which is pushing for controlling community spread plus vaccines and treatments, saying that there's a huge danger in allowing the disease to run riot. In other words, going much more closely to what the chief or what the public health leaders have said to the chief medical officers. So it's a very quick 15-minute survey through some of the medical questions, and I'll come back to see me again.
Yeah, that was absolutely fantastic. I'm just enabling my video again. That was a really brilliant compressed summary. Would you be willing to share those slides so we can give them to participants later?
Yes, of course. And I can also give you all of the references to the links that I've, things I've shown, so that people can go back and read them for themselves. Yeah,
that'll be fantastic. Loads of questions that came. Quick question about T-cell immunity, because the amount of immunity in the population may be boosted by that. Do you have a view on that?
Yeah, this is a difficult question. But the criticism has been that if you look at seroprevalence alone, in other words, people have got antibodies and therefore have definitely had the virus, it's as I say, about 8 to 10% in the Western countries which have been most heavily affected, like the US and UK. Now, what people are arguing is that there is immunity that's not being picked up, the T-cell immunity. So we have two kinds of immunity. We can produce antibodies, which attack viruses, or immunity through T cells, which are immune cells. And people argue that that in responding to other coronaviruses, we've built up a natural immunity to those. Now, the other two things that people bring up are, secondly, IgA, which is a form of immunoglobulin. Most of the tests for seroprevalence measure IgG or IgM, but not IgA, which is secreted on our membranes and might be making some people immune but not measurable. And then the other question, particularly in the developing world, not so much relevant in the UK, is whether the BCG, the TB vaccination, confers any immunity and whether this might be contributing to it. My own view is that, and I've read a lot on this, my own view is that people who raise these questions, they're all legitimate questions which are being discussed in medical journals. But what we haven't seen anywhere is a quantification of these factors. And I'm not aware of data which does quantify these things exactly. And that's why the best measure that we have at the moment is about antibodies or seroprevalence, because we know that these people have really had the disease. So when I read people saying, well, 60% are already immune because of T-cell immunity, BCG or IgA, I'd say, well, where's the evidence? It's not really there. And in fact, if you look at the two declarations that have come out, I'd have to say that the Great Barrington Declaration, some of which I agree with, but could never sign in conscience, because but is very much within the medical profession a fringe view. Most people are going with the more conservative view. Sure,
but I guess you'd call it a fringe view, but a fringe view not amongst non-medical, amongst medical people who have medical expertise. Just to be fair to them in that. It may be a minority view, but it's not a eccentric sort of non-specialist view.
No, and as I hope I've conveyed, there is really serious debate going on in peer-reviewed, high-level medical journals on these issues. Yes, it's not resolved. And I think when I said rather cynically that there's been an exponential increase in the number of people with PhDs in epidemiology and immunology, that there's far more certainty, it seems to me, in the general population on one view or the other than there is among epidemiologists or immunologists or doctors.
Yeah, that's interesting.
There are far many uncertainties than people give credit for. And I think that's perhaps a reflection of people living in bubbles, reading material coming from one side and not being exposed to all of the arguments across the board.
I guess some people would argue in terms of, and you alluded to it, but that the total number of deaths, maybe let's just take the UK, the total number of deaths by the end of this year will probably be similar or less to a typical year. probably. I think, but by some people's estimate anyway, not at least not significantly increased. That you would call it a sort of national crisis. Now you could say lockdown helped save that, but if all what that you were saying was true about other effects, other deaths caused, it does kind of raise lots of questions. So I guess you understand that that is a question. I don't know if you have a view on it about whether in squashing the curve, all we've done is just deferred deaths, but also created lots more deaths.
Well, again, and it may sound strange to say this, but I think it is still early days in terms of knowing all the facts. I mean, we don't even know exactly what the IFP, the infection fatality proportion, is, because we need more time to know it with certainty. I think the figures that we get in the UK, they have to be put against the fact that there are 600,000 deaths each year in the UK anyway from all causes. So 40,000 is less than 10% of that, even if you allow for excess deaths. And I think there's a lot of skepticism in the medical profession about the way the government is counting these deaths, only counting those who've been proven to have the virus up until 4 weeks after contracting it or showing symptoms, is going to underestimate substantially the number of deaths. So there are probably about 50% more deaths in the UK. Right. But when we look at the other effects on things like cancer, hypertension, diabetes, heart disease, and so on, it's impossible to quantify those yet. I think only time will tell. And if it is true that in this Western population, the infection fatality proportion is about 1%, then we would expect a much higher number of deaths if it were allowed to run through the whole population in Britain.
Can I ask a question that's on the chat, which is the World Health Organization infection fatality rate 0.23. Would you like to comment on that? This is from William Philip. Speak.
That is, no, I don't think that figure is correct. And I don't think it comes from the World Health Organization either. I think that comes from one particular person who's writing about this. Is a study from a guy called John Ioannidis, which has been widely quoted at the moment. Yeah. No, I'm not with him. I think you'd have to go back and read Rod Jackson's article in the New Zealand Medical Journal, Professor of Epidemiology in Auckland, as to why he thinks the rate is much higher and why so many estimates cannot be relied upon, because they're being done on incomplete populations that either aren't fully reflective of the age structure within the population or don't involve big enough numbers.
Could you, as I'm sure I get asked to quite a lot, comment on the Swedish model? And connected with that, I think that some people would say that the peak started to level off and drop even before lockdown happened, with some basic kind of hygiene measures that we'd started a few weeks before then. Any view on that?
Yeah, no, the first question on Sweden, if you look at Sweden, remember Sweden's got a very small population. So you need to look at the number of deaths per million population. And it's up around, I haven't checked it in the last week or so, but it's up around 600 deaths per million. Now, that's getting up to the level of, that's around the same level as the US, the UK, and so on. If we think about New Zealand, which has had 5 deaths, then, well, you can do the maths. It's more than 100 times that. So Sweden has not been successful in stopping deaths. And more than 90% of all the deaths in Sweden have occurred in care homes amongst very vulnerable elderly people. So they did very, very badly with that. So I don't think Sweden is any great model. And that's certainly the view of people in our fellowship from Sweden. Your other question, just remind me.
It was more whether the slowdown already started before full lockdown, because it was influenced either by the natural course of the virus, or it was influenced by the sort of lower level hand, face, space type things that we were doing before lockdown.
Yeah, well, as I said, I don't think it's natural level of the virus, because there's no evidence to suggest that, 80% of or 60% or whatever of people had immunity to start with from other causes like, T cells and so on. I think that we know that the peak in Britain appeared about the time we thought it would, around the 10th of April, which was about 2 or 3 weeks after lockdown, because lockdown was incredibly effective in suppressing the spread of the virus and driving the R number well below 1. But I think as well before that, as I said earlier on, social distancing, hand hygiene, and later masks, but certainly the first two, are incredibly effective at slowing down the spread of the virus. So it wasn't just about lockdown. I think that lockdown was necessary in Britain back in March. Whether it's necessary now is much more of a moot question. And I'd go personally much more with the public health leaders who are suggesting a more nuanced approach between lockdown and release.
That's brilliant. We're almost out of time. I have one final question, I think, although there's lots on the chat, which a bit more detailed. I have a question, which is, if you were on Sage right now, what would you advise the government to do? Particularly if you were the only advisor on Sage and it was your gift to determine policy for the next few months. It's a completely unreasonable question, but it's a fun one.
Well, it is completely unreasonable, and I'm not going to answer it because I don't really know the answer. And I certainly don't have the expertise to advise government on this. And I think my main burden is to help people to understand how complex this problem is, yes, and how difficult it is, and how you need people coming from all different perspectives and views, with expertise in everything from economics to healthcare to government and so on, to get it right. I think Britain made a lot of very serious mistakes at the beginning, which is why they're not in the position that New Zealand or Taiwan are for now. But, I take my hat off to those who are in the position where they have to make these decisions in the best possible evidence-based way. I think a nuanced approach now is probably the best one given where we are. But it's like asking the Irishman for directions, isn't it? He'd say, well, I wouldn't start from here. And I think if we could have gone back to February or March, we would be in a very different situation if Britain had handled things differently right at the beginning.
Yeah, and I appreciate that. And I guess your answer, though, illustrates the complexity, but also the lack of clarity of a clear policy decision. And it's partly why we need to pray for our leaders, because they're having to digest lots of presentations like the one you've just given, all with their own kind of, I suppose, biases and experiences and so forth, and try and create policy out of it. So I have an awful lot of sympathy for that. Thank you so much for that presentation. That was so dense and compressed, but dense in a good way. And we will appreciate looking at the slides later as well. So appreciate that very much. For everybody.